So till now we have seen the classification in that we have seen the bronchodilators. There are three classes of bronchodilators, that is a beta 2 sympathomimetics. We have already seen the drugs salbutamol, terbutaline, bambuterol, salmeterol, etc. etc. Then methylxanthines we have seen in that theophylline we have seen. And now let's move towards the anticholinergic, that is a third class of these bronchodilators. In this anticholinergics, we are going to see about the mechanism of action and drugs. Drugs we will study ipratropium and tiotropium, and uses and dosage we will see here. So let's start with the anticholinergics, that is a mechanism of action. Basically, the drugs produced bronchodilation by blocking cholinergic constrictor tone. Means atropinic drugs cause bronchodilation by blocking cholinergic constrictor tone and act primarily in the larger airways. Whatever we have seen, the lungs diagram, in that bronchodilation in the larger airways this drug is affecting. Now inhaled ipratropium bromide is less efficacious than sympathomimetics here, and here combination of ipratropium with beta 2 agonist causes more marked and long lasting bronchodilation. So, patients of asthmatic bronchitis like COPD and psychogenic asthma responds better to anticholinergics. Basically, in this type of patients, we are using these anticholinergic drugs. Here, inhaled ipratropium and triotropium are the bronchodilators of choice in COPD basically. They produce a slower response than inhaled sympathomimetics and are better suited for regular prophylactic use. Nearly ipratropium 2 to 4 puffs. Puffs means they are just inhaling with the help of that instrument. So 2 to 4 puffs 6 hourly, or tiotropium ka 1 rotacap OD they can take. This actually prophylactic use than for normal of an acute attack of asthma, and the combination of inhaled ipratropium with a beta 2 agonist produces more marked and longer lasting bronchodilation, and it can be utilized in the severe asthma. Then even nebulized ipratropium mixed with salbutamol is employed in refractory asthma, and combined formulations are also available with these both drugs, that is ipratropium and salbutamol. So these are the uses, that is asthmatic bronchitis, COPD patients, and psychogenic asthma. Now let's move towards the dosage of anticholinergics. Here Diolin inhaler, that is 100 plus 20 microgram per meter dose is given. Diolin is nothing but the salbutamol and ipratropium combined dosage form, which is available in the market. And then Diolin rotacap 200 plus 40 microgram per rotacap, and Diolin repsules 2.5 mg and 500 microgram in 2.5 ml of solution. So these are the dosage form of anticholinergic drug. Now let's see about the leukotriene antagonist. Let's see about the leukotriene antagonist, mechanism of action, pharmacokinetics, and drugs we are going to study here: montelukast and zafirlukast. Then side effects of the drugs and dosage. Before starting this leukotriene antagonist, just remember both these two drugs are within the chemical family of cysteine leukotrienes antagonist. So let's see about the pharmacokinetic. This montelukast and zafirlukast are well absorbed orally and highly plasma protein bound and metabolized by cytochrome P2C9. This montelukast by cytochrome P3A4, and the plasma half-life of montelukast is 3 to 6 hours, while that of zafirlukast is 8 to 12 hours. This is about the pharmacokinetics. Let's see about the mechanism of action of leukotriene antagonist. Since it was realized that cysteine leukotrienes are important mediators of bronchial asthma, many efforts were made to develop their antagonist and synthesis inhibitors. Two cysteine LT1 receptor antagonists, that is montelukast and zafirlukast, are available in the market in this formulation. So this montelukast and zafirlukast both have similar actions and the same clinical utility. They competitively antagonized cysteine LT1 receptor, which is mediated bronchoconstriction and increased vascular permeability and recruitment of eosinophils. Bronchodilation, reduced sputum eosinophil count, and suppression of bronchial inflammation and hyperreactivity are noted in asthma patients. Parameters of lung function show variable but definite improvement with this treatment. Some studies have also found that certain patients are responders while others are non responders to anti LT therapy. This montelukast and zafirlukast are indicated for prophylactic therapy, basically of mild to moderate asthma as alternatives to inhaled glucocorticoids. Though overall efficacy is lower than inhaled steroids, they may obviate need for the latter and may be more acceptable in children. In severe asthma, they may permit reduction in steroid dose and need for rescue beta 2 agonist inhalations. However, they are not be used for terminating asthma episode. The cysteine LT1 antagonists are effective in aspirin-induced asthma. Both this in side effects, both montelukast and zafirlukast are very safe drugs. Produce few side effects like headache and rashes. Eosinophilia and neuropathy are infrequent. Few cases of Church-Strauss syndrome have been reported in the side effect. And the dosage of montelukast and zafirlukast: montelukast 10 mg OD in children 2 to 5 years, 1 mg OD, and 6 to 14 years 5 mg OD. In the zafirlukast, that is Zuvair is the drug which is available in 10 mg and 20 mg tablets. This zafirlukast 20 mg BD, children in 5 to 11 years 10 mg BD. So this is about the leukotriene antagonist. Now, drugs for bronchial asthma, the third class is mast cell stabilizers. Let's see the pharmacokinetic. Here in mast cell stabilizers, we will study about the sodium chromoglycate and ketotifen. These two drugs we will study in mast cell stabilizers. So pharmacokinetic of sodium chromoglycate first we will see. This sodium chromoglycate is not absorbed orally. It is administered as an aerosol through metered dose inhaler, which is delivering 1 mg per dose, and that is a 2 puffs 4 times a day. The earlier spin inhaler capsules formulations delivering the drug as a fine powder. It has become less popular nowadays. Only a small fraction of the inhaled drug is absorbed systemically in this dosage form. This is rapidly excreted, unchanged in urine and bile. This is about sodium chromoglycate. Now let's see the pharmacokinetic of ketotifen. This ketotifen is absorbed orally. Bioavailability is 50% due to the first pass metabolism, and it is largely metabolized. T-half is 22 hours. Now let's see the mechanism of action. This two drugs, that is a sodium chromoglycate and ketotifen, it is a synthetic, this sodium chromoglycate, it is a synthetic chromone derivative which inhibits degranulation of mast cells as well as other inflammatory cells by triggering stimuli. Here release of mediators of asthma like histamine, then leukotrienes, then PF antagonist, interleukins, etc. is restricted. And the basis of this effect is not well understood yet, but may involve a delayed chlorine channel in the chlorine ion channel in the membrane of these cells. So, chemotaxis of inflammatory cells is inhibited, and the long term treatment decreases the cellular inflammatory response. Bronchial hyperreactivity is also reduced to variable extents. Bronchospasm induced by allergens, irritants, cold air, and exercise may be prevented. However, antigen antibody reaction is not interfered with this. It is also not a bronchodilator and does not antagonize constrictor action of histamine, acetylcholine, leukotrienes, etc. Therefore, it is ineffective if given during an asthmatic attack. In ketotifen, it is a antihistaminic that is H1 with some chromoglycate like action, stimulation of immunogenic and inflammatory cells that is a mast cells, macrophages, eosinophils, lymphocytes, neutrophils, and mediator release are inhibited here. It is not a bronchodilator but produces sedation. So this is the mechanism of action of both the drugs. Then uses this sodium chromoglycate used in the bronchial asthma, allergic rhinitis, and allergic conjunctivitis also. In bronchial asthma, this sodium chromoglycate is used as a long-term prophylactic in mild to moderate asthma. Decrease in the frequency and severity of attacks and improvement in lung function is more likely in extrinsic, that is atopic and exercise induced asthma, especially in younger patients. Then therapeutic benefit when it occurs develops slowly over 2 to 4 weeks and last 1 to 2 weeks after discontinuing. However, the prophylactic effect of chromoglycate is less marked and less consistent than that of corticosteroids. Its popularity has declined nowadays. Then in allergic rhinitis, this chromoglycate, sodium chromoglycate, is not a nasal decongestant but a regular 4 times daily prophylactic use as a nasal spray which produces symptomatic improvement in many patients after 4 to 6 weeks. Of course, need for nasal decongestant is reduced for this drug. Then in allergic conjunctivitis, regular use as a eye drops is beneficial in some chronic cases. And in a ketotifen uses, after 6 to 12 weeks of use, it reduces respiratory symptoms in 50% patients of bronchial asthma. But improvement in lung function is marginal with this drug. It also produces symptomatic relief in many patients with atopic dermatitis, perennial rhinitis, conjunctivitis, urticaria, and food allergy. Thus, it is especially indicated in patients with multiple disorders. Now, let's move towards the adverse effects of sodium chromoglycate. First, we'll see because of poor aqueous solubility of sodium chromoglycate, absorption of chromoglycate is negligible and systemic toxicity is also minimal. Then bronchospasm, throat irritation, and cough occurs in some patients, especially with fine powder inhalation. It may be allergic in nature. Then rarely nasal congestion, headache, dizziness, arthralgia, rashes, and dysuria have been reported with sodium chromoglycate. And with ketotifen, uh, generally well tolerated, this ketotifen. Sedation and dry mouth are common. Other side effects are dizziness and nausea, weight gain with a ketotifen. Then dosage. Sodium chromoglycate with a fentanyl inhaler 1 mg meter dose aerosol 2 to 4 puffs daily. Then fentanyl nasal spray. Then fentanyl eye drops are available for sodium chromoglycate. Then ketotifen It's a Astafen 1 mg tablet, 1 mg, that is a 5 ml serum. So this is about the mast cell stabilizers.